RN Link presents patient safety indicators with 2025 updates. You can also obtain the 1 CEU certificate for $20 by clicking the link below on the description section. The presentation offers 1 CEU approved by BRN and accepted by ACDIS and AHIMA. Learning objectives. At the end of the course you will learn: what is patient safety indicators? What is the impact on the facilities in regards to patient safety? Who in your facilities are monitoring the patient safety? Descriptions of the PSI on hospital-level indicators. Example of queries. How to avoid denials. Examples of appeal process. Disclaimer. This material is designed and provided to communicate information about clinical documentation, coding, and compliance in an educational format and manner. The presenter is not providing or offering legal advice but, rather, practical and useful information and tools to achieve compliant results in the area of clinical documentation, data quality, and coding. Every reasonable effort has been taken to ensure that the educational information provided is accurate and useful. Applying best practice solutions and achieving results will vary in each hospital/facility and clinical situation. Spot the mistake and take action. What is patient safety indicators? Patient safety indicators are a set of metrics developed by the Agency for Healthcare Research and Quality to help identify potential in-hospital complications and adverse events that might result from healthcare errors. These indicators are used for quality improvement, benchmarking, and hospital performance assessment. Purposes of PSI. PSIs are used for 1. Quality improvement, identifying areas for patient safety enhancement. 2. Benchmarking and public reporting, comparing hospital performance. 3. Risk adjustment and reimbursement. Some PSIs impact CMS payment programs, example, Hospital-Acquired Condition Reduction Program. Role of patient safety indicators in the hospital. Help hospitals identify and address potentially avoidable safety events, enabling them to improve care delivery and reduce harm, ultimately leading to better patient outcomes and improving the overall healthcare. 1. Identifying problem areas. 2. Focus on preventable events. 3. Data-driven improvement. 4. Benchmarking and comparison. 5. Focus on hospital-acquired complications. 6. Improving patient safety. Use of PSI to improve patient safety. Patient safety can be enhanced by improving the care environment, through changes like electronic medical records and increasing staff awareness of risks. Clinical interventions reduce adverse events related to hospital care. PSIs help prioritize and evaluate initiatives, such as synthesizing best practices from scientific literature, collaborating across disciplines to redesign care, assessing IT solutions, implementing performance metrics for accountability, hospital-specific guidelines for risk adjustment. When dealing with PSIs, hospitals can implement documentation best practices, risk adjustment strategies to ensure accurate reporting and avoid penalties. Below are key guidelines tailored to risk adjustment documentation. Risk adjustment ensures that PSIs reflect true quality issues rather than patient complexity. Proper documentation can prevent unnecessary PSI reporting. Key risk adjustment strategies are: 1. Present on admission status. Ensure all chronic conditions, examples are CKD, COPD, chronic respiratory failure, are documented at admission. Query providers if POA status is unclear. 2. Comorbidities and severity documentation. Capture conditions affecting SOI, severity of illness, and ROM, risk of mortality, such as sepsis PSI 10, post-op AKI. Pulmonary hypertension PSI 11, post-op respiratory failure. Chronic kidney disease PSI 10, AKI requiring dialysis. 3. Expected versus complication documentation. Providers should document if post-op ventilation greater than 48 hours was planned, to avoid PSI 11. If DVT prophylaxis was given but PE-DVT still developed, document DVT occurred despite appropriate prophylaxis, to reduce PSI 12 impact. 4. Clear surgical risk factors. Document patient-specific risks, such as high BMI, prolonged immobility, history of DVT-PE. Expected post-op fluid shifts leading to AKI. 5. Lung disease affecting post-op ventilation needs. Note, CDI action, develop queries ensuring these details are captured proactively. Provider-level PSI, hospital-specific. These indicators track in-hospital complications for benchmarking and quality assessment. PSI 02, death rate in low-mortality diagnosis-related groups, DRGs. PSI 03, pressure ulcer rate. PSI 04, death rate among surgical inpatients with serious treatable complications. PSI 05, retained surgical item or unretrieved device fragment count. PSI 06, iatrogenic pneumothorax rate. PSI 07, central venous catheter-related bloodstream infection rate. PSI 08, in-hospital fall with hip fracture rate. PSI 09, postoperative hemorrhage or hematoma rate. PSI 10, postoperative acute kidney injury requiring dialysis rate. PSI 11, postoperative respiratory failure rate. PSI 12, perioperative pulmonary embolism or deep vein thrombosis rate. PSI 13, postoperative sepsis rate. PSI 14, postoperative wound dehiscence rate. PSI 15, unrecognized abdominopelvic accidental puncture or laceration rate. PSI 17, birth trauma rate, injury to neonate. PSI 18, obstetric trauma rate, vaginal delivery with instrument. PSI 19, obstetric trauma rate, vaginal delivery without instrument. PSI 90, patient safety and adverse events composite. Note, effective version 2019, the following indicators have been retired. PSI 16, transfusion reaction count. Exclusions for patient safety indicators technical specifications, version V 2024, September 2024. PSI 02, death rate in low mortality diagnosis related groups heading. Excludes hospital discharges with trauma, cancer, an immunocompromised state. Transfers to an acute care facility. PSI 03, pressure ulcer rate. Excludes discharges with length of stay less than 3 days. Principal diagnosis of stage 3 or 4, or unstageable, pressure ulcer or deep tissue injury at the same anatomic site. Severe burns, or with exfoliative skin disorders, and obstetric discharges. Secondary diagnosis code for deep tissue injury or unstageable pressure ulcer present on admission at the same anatomic site. PSI 04, death rate among surgical inpatients with serious treatable complications. Excludes transfers to an acute care facility. Discharges admitted from a hospice facility. PSI 05, retained surgical item or unretrieved device fragment count. Excludes discharges with principal diagnosis of retained surgical item or unretrieved device fragment. Discharges with a secondary diagnosis of retained surgical item or unretrieved device fragment present on admission. PSI 06, iatrogenic pneumothorax rate. Excludes discharges with principal diagnosis of non-traumatic pneumothorax. Discharges with a secondary diagnosis of non-traumatic pneumothorax present on admission. Chest trauma, rib fractures, traumatic pneumothorax and related chest wall injuries. With pleural effusion. With thoracic surgery, including lung or pleural biopsy, or diaphragmatic repair, with a potentially transpleural cardiac procedure. Obstetric discharges. PSI 07, central venous catheter-related bloodstream infection rate. Excludes discharges with discharges with a principal diagnosis of a central venous catheter-related bloodstream infection. Discharges with a secondary diagnosis of a central venous catheter-related bloodstream infection present on admission. Discharges with length of stay less than 2 days. Discharges with a cancer diagnosis, or discharges with an immunocompromised state. PSI 08, in-hospital fall with hip fracture rate. Excludes discharges with principal diagnosis of fracture. Secondary diagnosis of fracture present on admission. Diagnosis of joint prosthesis-associated fracture. Obstetric discharges. PSI 09, postoperative hemorrhage or hematoma rate. Excludes discharges with principal diagnosis of postoperative hemorrhage or hematoma. With a secondary diagnosis of postoperative hemorrhage or hematoma present on admission. Discharges in which the only operating room procedure is for treatment of postoperative hemorrhage or hematoma. Discharges in which the treatment of postoperative hemorrhage or hematoma occurs before the first operating room procedure. Discharges with a diagnosis of coagulation disorder. Discharges with medication-related coagulopathy present on admission. Discharges in which thrombolytic medication is administered before or on the same day as the first procedure for treatment of hemorrhage or hematoma. Obstetric discharges. PSI 10, postoperative acute kidney injury requiring dialysis rate. Excludes hospital discharges with principal diagnosis of acute kidney failure. Secondary diagnosis of acute kidney failure present on admission. Dialysis procedure before or on the same day as the first operating room procedure. Dialysis access procedure before or on the same day as the first operating room procedure. Cardiac arrest, severe cardiac dysrhythmia, shock, chronic kidney disease stage 5 or end-stage renal disease. With a principal diagnosis of urinary tract obstruction. Partial or total nephrectomy procedure on a solitary kidney, and obstetric discharges. PSI 11, postoperative respiratory failure rate. Excludes discharges with principal diagnosis of acute respiratory failure, a secondary diagnosis of acute respiratory failure present on admission, or any diagnosis of tracheostomy present on admission. Which tracheostomy is the only operating room procedure, or in which tracheostomy occurs before the first operating room procedure. Malignant hyperthermia, a neuromuscular disorder present on admission, or a degenerative neurological disorder present on admission. Laryngeal, pharyngeal, nose, mouth or facial surgery involving significant risk of airway compromise. Esophageal surgery, a lung cancer procedure, or lung or heart transplant. Treatment of respiratory diseases. All obstetric discharges. PSI 12, perioperative pulmonary embolism or deep vein thrombosis rate. Excludes discharges with a principal diagnosis of pulmonary embolism or proximal deep vein thrombosis, or with a secondary diagnosis of pulmonary embolism or proximal deep vein thrombosis present on admission. With heparin-induced thrombocytopenia, discharges in which interruption of the vena cava or a pulmonary arterial or dialysis access thrombectomy occurs before or on the same day as the first operating room procedure, or is the only operating room procedure. Discharges with extracorporeal membrane oxygenation. Discharges with acute brain or spinal injury present on admission. Discharges where the first operating room procedure occurs after or on the 10th day following admission. Obstetric discharges. PSI 13, postoperative sepsis rate. Excludes discharges with a principal diagnosis of sepsis, or with a secondary diagnosis of sepsis present on admission. Discharges with a principal diagnosis of infection, or with a secondary diagnosis of infection present on admission. Discharges where the first operating room procedure occurs after or on the 10th day following admission. Obstetric discharges. PSI 14, postoperative wound dehiscence rate. Measure can be stratified to report events by whether patient underwent open or non-open procedure. Excludes discharges in which the last abdominal wall reclosure procedure occurs on or before the date of the first abdominopelvic surgery. Discharges with a principal diagnosis of disruption of internal operation surgical wound, with a secondary diagnosis of disruption of internal operation surgical wound present on admission, or with hospital length of stay less than 2 days. Obstetric discharges. PSI 15, unrecognized abdominopelvic accidental puncture or laceration rate. Excludes discharges with accidental puncture or laceration as principal diagnosis. Discharges with accidental puncture or laceration as a secondary diagnosis present on admission. Discharges in which the index and/or all subsequent abdominopelvic procedure dates is/are missing. Obstetric discharges. PSI 17, birth trauma rate, injury to neonate. Excludes discharges of preterm infants with a birth weight less than 2,000 grams. Discharges with osteogenesis imperfecta. PSI 18, obstetric trauma rate, vaginal delivery with instrument. Excludes discharges with a principal ICD-10 cm diagnosis code assigned to MDC-15 newborns and other neonates with conditions originating in perinatal period. With an ungroupable DRG, DRG 999. With missing gender, sex equals missing, age equals missing, quarter, DQTR equals missing, year equals missing, or principal diagnosis, DX1 equals missing. With missing MDC, MDC equals missing, when the user indicates that MDC is provided. PSI 19, obstetric trauma rate, vaginal delivery without instrument. Excludes discharges with instrument-assisted delivery. PSI 90, Patient Safety and Adverse Events Composite. No exclusions. PSI and CDI. Since PSIs often depend on accurate coding and documentation, CDI professionals play a crucial role in ensuring the proper capture of patient conditions. Some key CDI-related considerations include postoperative respiratory failure, PSI 11, ensuring clear documentation of whether respiratory failure is due to an expected post-op course or a true complication. Perioperative PE/DVT, PSI 12, documenting whether a DVT or PE was pre-existing versus post-op acquired. Acute kidney injury, PSI 10, clarifying whether AKI is due to post-op complications or another underlying condition. Query development for patient safety indicators, PSIs. Since PSIs rely heavily on accurate documentation and coding, query development is crucial for clarifying whether a condition is truly a complication or an expected outcome. Many hospitals have specific CDI and coding policies regarding 1. Clinical validation before PSI reporting. 2. CDI physician queries for POA clarification. 3. PSI appeals process with payers. Sample queries. PSI 03, pressure ulcer rate, POA versus hospital-acquired wound. Scenario. A stage 3 or 4 pressure ulcer is documented, but the provider did not state whether it was present on admission or acquired during hospitalization. Query example. Dear provider, the medical record includes a stage 3 or 4 pressure ulcer, but its onset is unclear. Can you clarify if this condition was present on admission, hospital acquired, unable to determine? Note, CDI tip, if POA is not documented, the ulcer may default to hospital acquired, impacting PSI rates and reimbursement. Note, rationale, clarifies whether the ulcer was pre-existing, avoiding PSI assignment, or hospital-acquired, requiring reporting. PSI 12, perioperative pulmonary embolism or deep vein thrombosis, prophylaxis documentation challenge. Scenario. A PE/DVT is documented after surgery, but it's unclear if DVT prophylaxis was given and whether the PE/DVT was preventable or expected. Query example. Dear provider, the patient was diagnosed with a pulmonary embolism or deep vein thrombosis postoperatively. Can you clarify? The PE/DVT was present on admission. The PE/DVT developed postoperatively despite appropriate prophylaxis. The PE/DVT developed due to lack of prophylaxis, please specify reason. Other, please specify. Unable to determine. CDI tip, documenting whether prophylaxis was given is crucial in risk adjustment, preventing unnecessary PSI reporting. Rationale, ensures appropriate PSI assignment and prevents misclassification of pre-existing conditions as hospital-acquired. PSI 08, in-hospital fall with hip fracture, clarifying timing and cause of fracture. Scenario. A hip fracture is documented in a patient's record, but it's unclear whether it was present on admission or occurred due to an in-hospital fall. Query example. Dear provider, the record documents a hip fracture, but its origin is unclear. Can you clarify whether this condition was present on admission, the result of a documented in-hospital fall, due to osteoporosis or pathological fracture. Other, please specify. Unable to determine. CDI tip. Clearly distinguishing POA fractures from hospital-acquired fractures prevents incorrect PSI assignment. Rationale. Prevents misclassification of pre-existing fractures as hospital-acquired conditions. PSI 10. Postoperative acute kidney injury requiring dialysis, sepsis versus surgical complication. Scenario. A patient develops AKI requiring dialysis postoperatively, but documentation does not specify whether it was due to sepsis, dehydration, or a direct surgical complication. Query example. Dear provider, the patient required dialysis following surgery, but the etiology of AKI is not specified. Can you clarify the underlying cause? Postoperative complication. Due to sepsis or infection. Due to hypovolemia/dehydration. Pre-existing chronic kidney disease, please specify stage. Other, please specify. Unable to determine. CDI tip. If AKI is due to sepsis or another pre-existing condition, it may not be classified as a postoperative complication, PSI 10, preventing unnecessary reporting. Rationale. Helps differentiate post-op complications from other causes like sepsis or chronic kidney disease. PSI 11, postoperative respiratory failure, clarifying acute versus chronic and POA status. Scenario. A patient is documented with respiratory failure postoperatively, but the provider hasn't specified whether it's an acute, chronic, or expected post-op course. This can lead to incorrect PSI assignment. Query example. Dear provider, the medical record indicates that the patient required prolonged mechanical ventilation, greater than 48 hours, after surgery. To ensure accurate coding, can you clarify the clinical significance of this respiratory status? Expected post-op course, not a complication. Acute post-op respiratory failure. Chronic respiratory failure. Due to underlying lung disease, please specify. Other, please specify. Unable to determine. CDI tip. Ensure expected post-op respiratory support is clearly differentiated from true respiratory failure to avoid unnecessary PSI reporting. Rationale. Helps distinguish between an expected post-op course and a complication that impacts PSI reporting. PSI audits, appeals, and documentation training. PSI processes with payers. Hospitals can appeal PSI penalties if there is strong clinical documentation to support that a reported PSI was clinically expected rather than a true complication. Related to patient risk factors, not hospital quality issues. Misclassified due to coding errors or lack of provider specificity. Since patient safety indicators impact hospital quality scores and reimbursement, hospitals benefit from a structured audit, appeal, and training process to ensure accurate reporting. Below is a tailored approach to each. 1. PSI audits, identifying and preventing errors. Audits help hospitals identify cases that may be incorrectly flagged and ensure that only true complications are reported. 2. PSI appeals, correcting misclassified cases. When a PSI is incorrectly assigned, hospitals can appeal to payers to avoid penalties. 3. PSI documentation training for providers and CDI teams. To reduce PSI rates, hospitals should educate providers on proper documentation practices. Let's dig in deeper to each approach in the next slides. PSI audit process. 1. Review present on admission status. Ensure conditions are not mistakenly labeled as hospital-acquired. 2. Validate clinical criteria. Confirm that the documented complication meets AHRQ-PSI definitions. 3. Assess risk adjustment factors. Identify comorbidities that justify patient outcomes and prevent unfair penalties. 4. Check provider documentation for specificity. Ambiguous language can lead to incorrect PSI reporting. Example PSI audit question. Was post-op respiratory failure, PSI 11, truly unexpected, or was prolonged ventilation planned due to comorbid conditions? CDI role. Implement pre-bill PSI audits to catch errors before reporting to payers. PSI appeals. Correcting misclassified cases. Common PSI appeal scenarios and strategies. PSI 11. Postoperative respiratory failure. Appeal if the patient had pre-existing chronic respiratory failure, example, COPD, obesity, hypoventilation. Mechanical ventilation was expected due to surgical risk factors, example, thoracic surgery. Argument: patient had pre-existing COPD and obesity, requiring planned ventilation postoperatively. Not an unexpected complication. Appeal evidence needed. Pre-op pulmonary risk documentation. Clear statement in provider notes. Prolonged ventilation expected due to specify condition. PSI 10. Postoperative acute kidney injury requiring dialysis. Appeal if the acute kidney injury was due to sepsis, dehydration, or nephrotoxic meds rather than the surgical procedure. The patient had pre-existing CKD, and dialysis was planned. Argument: acute kidney injury was secondary to sepsis-related hypoperfusion, not a direct surgical complication. Appeal evidence needed. Sepsis diagnosis and timing. Labs showing pre-existing renal dysfunction. Provider statement linking acute kidney injury to sepsis. CDI role. Work with quality, coding, and appeals teams to ensure strong clinical validation for appeals. PSI 12. Perioperative DVT/PE. Appeal if DVT prophylaxis was given per guidelines, but the patient still developed a clot. The patient had increased clotting risk factors, example, cancer, clotting disorder. Argument: DVT prophylaxis was administered, but patient had high thrombotic risk due to malignancy. Appeal evidence needed. Prophylaxis orders and administration. Documented risk factors in HNP. CDI role. Work with quality, coding, and appeals teams to ensure strong clinical validation for appeals. PSI documentation training for providers and CDI teams. Key training topics. 1. How to document POA conditions, prevent misclassification of pre-existing conditions. 2. Expected versus complication language. Avoid unclear phrases like respiratory failure without context. 3. Risk factor documentation. Ensure all comorbidities are captured for risk adjustment. 4. Real-world PSI case studies. Teach providers how PSI documentation affects hospital quality scores. Custom tools for your hospital. 1. PSI audit checklists. Structured guides to help CDI teams and coding staff review high-risk PSI cases before submission. 2. Sample PSI appeal letters. Pre-written templates that align with payer appeal requirements for common PSI disputes. 3. Customized provider training materials, slide decks for medical staff meetings. Quick reference pocket guides. Short videos on PSI documentation pitfalls. 4. Custom PSI query templates, CDI-friendly queries that help clarify complication versus expected outcome, ensuring accurate risk adjustment. CDI role: implement real-time documentation coaching for high-risk PSI cases. Sample of PSI audit checklists. 1. Confirm PSI trigger criteria met. Validate that the PSI meets the definition as per AHRQ guidelines. Review coding assignments and DRG validation. 2. Verify present on admission status. Ensure that conditions present on admission, POA equals Y, are not mistakenly reported as hospital-acquired. Query providers if POA status is unclear. 3. Assess clinical validation and risk adjustment factors. Confirm relevant comorbidities and severity of illness are documented. Evaluate whether patient-specific risk factors justify the event. 4. Review provider documentation for specificity. Check if complications were expected or planned, example, prolonged ventilation after surgery. Ensure terminology is accurate and not misleading. 5. Confirm prophylaxis and preventative measures were followed. Ensure documentation of appropriate prophylactic measures, example, DVT prophylaxis, infection prevention protocols. Identify gaps in clinical documentation that may misrepresent patient safety events. Example of patient safety indicator appeal letter template. Write in your hospital name, address, phone number, date. 2. Insurance company or CMS contact. Address. Subject: appeal of PSI, insert PSI code and name, insert claim number. Dear Medical Director/Review Officer, we are writing to formally appeal the classification of a patient safety indicator, PSI, on the above referenced claim involving our patient initials or identifier, treated at, hospital name, on, dates of service. After careful review of the medical record and coding, we believe this case has been incorrectly flagged as PSI, code, name. Below is a clinical summary and justification for appeal. Example of patient safety indicator appeal letter template. Write in your hospital name, address, phone number, date. 2. Insurance company or CMS contact. Address. Subject: appeal of PSI, insert PSI code and name, insert claim number. Dear Medical Director/Review Officer, we are writing to formally appeal the classification of a patient safety indicator, PSI, on the above referenced claim involving our patient initials or identifier, treated at, hospital name, on, dates of service. After careful review of the medical record and coding, we believe this case has been incorrectly flagged as PSI, code, name. Below is a clinical summary and justification for appeal. Provide the patient information. Patient name/ID. Date of admission. Date of discharge. Primary diagnosis. Procedures performed. PSI identified, PSI, code, PSI name. Appeal reason: choose one or more. Condition was present on admission. Complication was clinically expected/planned due to underlying comorbidities. Preventive measures were in place, but patient developed the complication due to unmodifiable risk factors. PSI assignment was due to documentation or coding misinterpretation. Clinical summary and supporting argument. Provide a brief yet thorough clinical narrative explaining why the PSI is not valid. Include key supporting documentation references, example, provider notes, operative report, POA status, risk factors. Example below. The patient was admitted with severe COPD and obesity hypoventilation syndrome. Postoperatively, the provider documented that mechanical ventilation greater than 48 hours was expected due to poor pulmonary reserve. There is no evidence of unexpected respiratory deterioration or reintubation. As such, PSI 11, post-op respiratory failure, does not apply in this case. Supporting documentation included if applicable are: operative report, progress notes, HNP and discharge summary, medication administration record, if applicable, POA indicators and coding summary. Based on the clinical facts and supporting documentation, we respectfully request removal of PSI, insert code, from this encounter. Please contact us with any questions or if additional documentation is needed. Sincerely. Your name. Your title, example, CDI Specialist, Director of HIM, Quality Manager. Email address. Phone number. In summary, how PSI impact hospitals. Hospitals must monitor, document, and improve patient safety to reduce PSI rates. PSI's effect. 1. CMS's HAC reduction program. Low-performing hospitals may lose 1% of Medicare reimbursement. 2. Public quality scores. Example, Leapfrog, Hospital Compare. 3. Risk adjustment and appeals. Accurate documentation can prevent incorrect PSI reporting. Key CDI role. Ensure that PSs are correctly documented and do not capture expected clinical scenarios as complications. These are the references used for this presentation. If you have any questions, please feel free to contact us via email at rnlink2016@gmail.com. Thank you for watching. Make sure to click subscribe, follow, and like to stay updated with our latest content. For just $20, you can access 1 hour of continuing education by clicking or copying the link below. To earn your certificate, simply pass the test and complete the evaluation.